Saskatchewan. There you go. All right. I think we got everybody on. All right, team, let's get rolling. If you don't know me, my name is Robert Linkul, and it's my very good friend, Evan Osar. And every couple of weeks, I host a webinar called the Solution Sessions, and that's what today is. Sometimes it's a open discussion back and forth. Other times it is little mini presentations for us to share as much information as we can in this hour. And then pending how much time we have between Evan and I'm always happy to stay on and answer questions. We can do some Q&A at the end for 10 or 15 minutes. And we are here for you guys. So as we're going, we will not stop mid-presentation to take Q&As, but if you have questions on things as they come up, throw them on the Q&A box and we'll tackle all those at the end. Evan is going to kick us off. He's going to kind of go through his little mini presentation here. We might have some little discussion points between he and I as we go through, and about halfway through, I'll switch and take over. Really what the focus is for us is to bring you as much applicable information as possible, stuff that you can apply right away, understanding why and how we got this information, how we like to apply it, why we want to apply it, and then how you can start to practice some of those things in. So some of this will be rather specific, some of it will be a little bit more broad, but really we want to give you some stuff that you can use with your people right away. And our focus with today is really specific around the knee and the hip. And for me, kind of the knee and the hip, and Evan, I'll let you kind of discuss this as well as you kick us off. I feel like the knee and the hip and the back are all very similar in the ways that you would modify, progress, regress, and coach and cue movement. So really we could kind of throw the back in here too. Exactly. Yeah, so I'll let you fire away, my man. Take off. You got, let's say 25 minutes, and then we'll do a little switcheroo. Sound good?
Perfect. Sounds awesome. Thank you so much for having me on. Thanks for everybody for joining us, whether you're watching this or listening to this live or you're watching the recording. I truly, truly appreciate it. My name is Dr. Evan Osar. I work with my wife in Chicago, Illinois. We have a clinic, small clinic, Chicago Integrative Movement Specialists, and we also train coaches, fitness professionals, massage therapists, physical therapists, chiropractors around the world in our system, the Integrative Movement System. And if you could slide to turn to the next slide, Robert.
Gotcha.
It's really about the process and the system that we use. And your results are only as good as your system. Therefore, I want you to really focus on your system and your process more than your exercises. And I love the quote by James Clear, the author of Atomic Habits. And that's definitely a book you want and need in your library, Atomic Habits by James Clear. And he says, you do not rise to the level of your goals, you fall to the level of your systems. And this is really important. When I read that, I'm like, this is 100% why the integrated movement system is such a valuable part of working with clients and how it can really help you level up, really be that best for your clients, and also differentiate yourself from the rest of the industry, because there's so many opportunities for your clients to go elsewhere. The internet, social media, other people down the street, your local box gym. But one way you can really differentiate yourself and really help more clients with hip, knee problems, as well as low back, as Robert mentioned, is to have the right system. If you want to click on the next slide, please. I want to share with you just a quick story about my client, Tony. Tony came to me with chronic low back pain and hip pain, as well as knee pain. And this happened in the change before and after happened in 30 minutes. And it's because we focused on the process versus the exercises. The goal is to help the client develop a more optimal and efficient strategy. Your clients will come to you and they may have a goal of getting stronger, maybe losing weight, maybe doing something like climbing a mountain or running a 5K. And it's really important that as part of your system and your process, you take your clients through that process. Describe and discuss the journey you're going to take them on, and not just focus on the outcomes. So really focus on your process. And like I said, this client was able to change like this. He's like, I feel like I have a butt now. When we looked at the before and after pictures, as well as like my abs are flatter. And he's like, I don't even feel like I'm trying. And that's the thing. I didn't have him just stand there and say, pull your abs in, squeeze down and back. This is just using the right process, the right system. And I'll share that with you in this webinar. Next slide, please. So there's three things I want you to know about the hips and knees. And this is very important because Robert will share with you his story if you're not familiar with his story. But this really became evident to me early on in my practice. I got to watch a hip replacement, and it's exactly as you would suspect it is. It's quite archaic in how it's done. It's like they cut through the muscles and then they dislocate the hip, they saw off the head of the femur, and then they hammer in a new femoral head, and then they put a new acetabulum in the socket, and then they put it back together and they sew things back up. And as I was watching this procedure, it was really amazing to me. Like, these surgeons are so awesome, because this woman was going to get up and walk within, a few hours after the surgery. And I'm like, this is incredible. But what also struck me, which really changed my perspective on hip and knee replacements and osteoarthritis, is this woman looked very young. So this is going back a few years, and I remember asking the surgeon, I'm like, how old is this woman? And he said to me, she's 50. And I'm like, so what happened? Car accident, fall, what happened to her hip? He's like, yeah, it's just old age. And I just turned 50 this year. And I'm like, what? Old age? I'm like, I have no plans of getting a joint replacement, God forbid, if as long as nothing happens to me. But it's like, it struck me that, like, maybe our knowledge around why people are getting joint replacements. Obviously, Robert, you have a unique story as well. But I'm like, this woman is really young to be getting joint replacements, and that is what I want to discuss with you. Why so many people are getting joint replacements and so early, because it's happening earlier and earlier. So three things I want you to know about the hips and knees is they're involved with three important functions: balance and walking. Obviously, that's one of the most important functions. Shock absorption. Your knee is a primary shock absorber of your body. And obviously, the hip and knee are part of the kinetic chain that helps propel us forward. Next slide. As you know, the hip joint is a ball and socket. You can click on the next portion of that. And the knee is a hinge joint, except the hinge joint, it's a hinge joint that moves in three planes of motion. And those three planes of motion are very important to normal mechanics. Because what they used to do is they used to do knee replacements with the hinge joint. And what happened, they found out pretty quickly, was people were busting through the screws because the knee actually moves in three planes of motion. And this is why so many people then ultimately create or develop knee problems, is because of the three planes of motion that the knee moves in. It flexes and extends. It also abducts and adducts, and it also will rotate. And the knee is a very common area where the body will make up rotation or compensate with rotation to make up for the goal. I should say the goal is to keep the eyes level to the horizon. So if you're rotated through your shoulders, through your thorax, through your hips, through your pelvis, through your feet, your knee is a very common area to start to rotate. And that's why we see that valgus knee position. That valgus knee position is actually it's more rotation than it is actually just pure abduction of the knee, or that valgus knee position. Is actually a rotation component involved with that as well. So as we're looking at our clients, one of the first things we want to do is get them aligned as possible, so that you're minimizing the rotations, the compensations, and that will also minimize the rotations through the knee, and therefore reduce a lot of stress upon the knee as well. Next slide.
Evan, has it been your experience that individuals that are experiencing chronic knee or hip or back injuries or issues also have one of the others that kind of accompany it? It's rare that I'll see, like, oh, I got a bad back, and they don't have a knee that they've been compensating with it forever that probably led to the back injury, right? Do you see those kind of mapping issues like that?
Absolutely. Because, like I said, the knee is really a great compensator. So a lot of the knee is compensating for maybe loss of mobility at the hip, or decreased spinal stability, or core stability. And the knees is just a nice area, a very common area that the individual will compensate. And we'll talk a little bit, hopefully we'll have time to talk about later on, where the knee should go when someone squats. So should we keep the knees behind the toes or not?
Gotcha.
And
that's a hot topic.
I want you to bring that topic up again, because that will relate directly to some research around the knee, and why people that have knee problems probably have hip or back problems, and people that have hip or back problems will probably develop knee or other issues. Yes, absolutely.
Cool.
So one of the things we see that commonly goes wrong is people become grippers, and what we refer to this as is butt grippers. The image is to the left is an athlete, a professional athlete. He was a professional NFL player, or he was, I should say. And his trainer asked me to take a look at him because he was having chronic low back pain. And you can see where Robert's pointing the arrow, the massive increase in spinal flexion. And why is he getting a massive increase in spinal flexion? And this is exactly to your point, Robert, is because he's not getting enough anterior pelvic rotation. So why does a professional athlete, someone who's trained to move and move well, supposedly, why is he not getting enough anterior pelvic rotation? Because he's gripping from his hips too much. And why do athletes grip from their hips too much? Is because their coaches teach them to do that. And that's what you and I talked about privately a few weeks ago. And with the deadlift and the hip hinge patterns, the hip thrusters, things like that, people are just over squeezing and driving that pelvis forward, over tightening and squeezing the glutes, and they lose the ability to get anterior pelvic rotation, which is basically your hip hinge position. If you could cue up that video right next.
Sure. Yeah, I see. Okay, I got it here.
And you'll see exactly what happens. And this is a woman, a client in the gym. I videotaped her in the gym, and you'll see her doing the exact same thing that we've all been taught to do with our clients. And she's just doing it because that's what she's been taught to do. And you'll see that massive drive of the pelvis towards the bar. And people are teaching, coaches are teaching in our industry to thrust your pelvis forward like you're doing something naughty to the bar. And this is exactly what's causing butt gripping and the inability to then, if you watch every single repetition, she gets worse and worse because she's not able to let go of the hips to create that anterior pelvic rotation. And that is actually, in the webinar, I said, we're going to talk about the number one strategy for helping the hip, the knee, as well as the low back. And that is, number one, I should say, is breathing. That's a whole nother topic we'll talk about another time.
I want to talk about that sometime.
Yeah, and number two is hip hinge. We just did our certification course last week, and it's a 3-day introductory course to the integrative movement system. I said there's two patterns that can change people's lives. Number one is breathing. Number two is the hip hinge. Because when you think about all our lower extremity patterns, the squat, the deadlift, the stepping, the lunging, they're all based off the ability to get anterior pelvic rotation. And when we look at our clients, the clients that struggle the most with balance, with hip issues, with knee issues, with back issues, what pattern do they lose the most? Number one is breathing. Number two is the ability to hip hinge. The lack of hip hinging is a number one reason. The lack of ability to get anterior pelvic rotation is a number one reason that will tear up your joints. And if you can give them back better breathing, better hip hinging, you will save so many people's lives. Because when you think about what deteriorates the older adult, it's a lack of activity. And so many people decrease in activity. Like I just had a brand new patient yesterday, came in, she needs a knee replacement. And she's like, I love to walk. I'm just not walking as much. So now I'm gaining weight. So you can see her health is already starting to go down because of this painful knee. So, and she had a very poor ability to get anterior pelvic rotation. So, and I know you're going to talk about that quite a bit here in a few minutes as well, Robert.
Well, we see this so much. This is one of the hard, as soon as you mentioned this the other day, I was like, that's exactly it. Because it's like one of those primal, teaching components that you see in powerlifting and the diehard CrossFitters and your tribal training. Yep. It's all about like, it doesn't count. The rep doesn't count unless you get to this full, lockout, butt squeeze, extension position.
Yes.
And, I've got an individual I'm working with right now. Actually, she's on here watching. And this is something we just fixed with her last week. And she's like, my back feels so much better just in not doing it this way. And it's like your basic mechanical breakdowns of anatomy kind of bring you back to the point of like, what do you think's happening to L3, 4, 5 into your sacrum, into, your sciatic nerve being pinched down that side? Like that excessive range, that's something we have to, unfortunately, as professionals, we have to detrain people to do, especially if they've come from another location, right? Or another pattern. So it's definitely something we got to come through, but you're also looking at the over dominance of hip flexor development and how tight we are there, and iliopsoas and all that pulling forward, like it's feeding to that anyhow,
Sure.
So now we've got that battle to work with, the sitting disease, quote unquote. I know that's been bastardized a bit, but we got a lot working against us here, but going through these mechanical pieces like this as we go through, I think that's going to deliver a lot of benefit from our end to be able to teach to our people. So
absolutely.
I'm loving this. Yeah.
Awesome. Next slide, please.
All right.
So essentially what we created, my wife and I created the integrated movement system, and it's really a systematic process, strategic process for us to work our clients from where they are, where they come to us, and where they want to go. So they have these functional goals that they want to achieve, their why, the things that they really need to, want to, and or love to do. The integrative movement system is just a strategic way to get them from here where they are to there, because they have things that they need to work on to get them to their goals. This is just a way of working them through it. And it's a 3-phase process: discovery, address, and integrate. The discovery phase is where you take your client history and you do your assessment. And your assessment should do Two things. Number one, they'll help you identify your client's non-optimal and inefficient posture and movement habits. These are the reasons why your client has chronic tightness, discomfort, and or inability to perform at the levels they need to or want to. The other important thing about your assessments is that it allows you to determine very accurately and right then and there whether or not you're having the results on your client that you think you are or want to have. Meaning, if you check hip rotation and you do your corrective exercises, which we'll talk about here in a few minutes, you should have increased hip range of motion, because that's what your corrective exercises should do. Address those reasons why your client's getting tight or having discomfort or just not performing at their best. However, if you now take them into a pattern and then they lose range of motion after that pattern, then you've done something in their pattern, or they've done something, I should say, in their pattern that has compromised their alignment, their breathing, or their control, and therefore the nervous system has compensated by decreasing range of motion. So your assessment, number one, will help you identify your client's current habits that are causing the issue, but then also allow you to determine the impact of your exercises, your strategy, and whether or not your client is maintaining their alignment, their breathing, their control. Because if your client is doing that well, they should maintain range of motion and or even gain range of motion as they're working through their program. Your workout and your exercise program should never cause your client to decrease range of motion or decrease their ability to breathe or decrease their stability, like standing on one leg. If you start to finally, your client is stable in the beginning after your correctives, and then they're starting to lose stability, that means their nervous system is getting fatigued and the nervous system is starting to lock down. And that's at the point where you need to backtrack a little bit or get your client reset, so that way you're not continually feeding them into these non-optimal and inefficient patterns that are causing them the issues in the first place.
So, Evan, when you go through your first assessment with people, and I know this might take us down a whole different path, but
Sure.
You're trying to get a true observation of what you're dealing with, but you're also trying to observe, I call it bilateral dominance, even though there really isn't such a thing, but it's like while performing a squat or a row or a push, which side are they favoring? Which side are they dominating with? Especially when they get to kind of that fatigue state, you'll see the hips shift and the right leg kind of take over with what they're doing. So not only are you assessing like the basic aspect of the movement, but which teasers are you getting of each side? Which piece are you seeing? Can you talk about that a little bit more too? And give me a little more info on how you do that?
Absolutely. Actually, you know what? If you could
is that coming
take me to the next, and
sure.
And then I'll
jumping the gun.
and then I'll explain that process.
You got it.
And then, if I don't answer it, go ahead and ask it again.
Gotcha. Yes,
so
sir.
The first thing we look at is posture, and there's a lot of debate now. That's another hot topic by social media gurus. I should say gurus, self-made gurus,
experts.
Right? Self-made experts, right? And they're like, oh, posture doesn't matter. There's no research that shows posture matters. I'm like, yes, there's lots of research that shows posture matters. Yeah. So it's like this. If your finger should be here and you should load your finger like this, if your finger's sitting over here like this, you probably shouldn't be loading your finger like that. Your hip joint, your knee joint, your spine is the exact same thing. Yeah. There is a best position for all of your joints, and there's a best position for loading. However, the one thing I do want you to take home is what I was not taught is I was sort of taught that posture sort of tells you a whole lot. Posture doesn't tell you anything except for the starting position, and that's very important. It shows you the starting position where the client is starting to load from. Are they starting from an optimal position, like where it should be, or are they starting from a non-optimal position? Because if they're starting non-optimal and they become more optimal, meaning like, so that the client, his knees rotated or in valgus, but then when they load up to a squat, you're like, hey, they actually align that knee pretty well. I'm not so worried about it. However, generally what you see in posture is a reflection of what they're going to do when they move. And this is exactly what you were talking about, Robert. You start to see this valgus knee position in standing, like you see my client with her left knee, the kneecap, she's got knee and big toe pain. So you see the left kneecap is pointing in, it's just slight. But again, when she starts loading that knee, it starts to rotate further in. That's what we're really looking for. The starting position is not ideal, not optimal. However, when she loads it up, when she goes into single leg stance, which will come up in our next assessment, and our squat, we want to see that she's able to align and control the hip, knee, ankle, and foot. And if we start to see more valgus or more rotation, then we know that that's a non-optimal strategy. Okay. Gotcha. Next slide. Now, remember I said you never base anything on posture alone. So my client there that has the internally rotated knee, you see what happens when she stands on single leg stance. When you think about this now, when you go from bilateral stance, you have half your weight on each leg. Half your body weight is on each leg. When you stand on single leg, now you have twice your body weight on your single leg. When you're walking to running, you're going now 3 to 7 times your body weight through that knee. And so, I was speaking at a conference, the medical fitness conference, and this woman was asking me, what are you speaking about? And I said, I'm talking about osteoarthritis of the knee and this and that. She's like, oh, I'm so glad you're doing this. I just did my master's thesis on why running is good for the knees and not bad for the knees. I'm like, well, then you're going to hate my presentation because running is very bad for your knees if you're running with the alignment that you see on the screen. If you're able to align the femur and the tibia, absolutely, you've got a good strategy for running. You're probably not going to tear up your knees. But if you even look at the research around it, there's a research study, and there's not a lot around running in the knees, but there's one research study I read recently, because I'm writing about this in my new book, is that running does not seem to increase osteoarthritis of the knees, which you're like, oh, yeah, see, so it doesn't affect the knees. But it said in individuals, you have to keep reading the study, it says in individuals that do not currently have osteoarthritis. So again, if you have proper alignment, running will not bother your knees. But if you're running like this, like my client is, running will definitely bother your knees, and it will lead you to early degenerative changes of the knees. So again, it all comes back to that alignment and how are you loading, and then what activities are you trying to put on top of your current strategy.
I have a reputation for not liking running, and really that's not the case. I don't like running poorly, because you see so many poor running mechanics. Egg beater legs, slouching, dominant to one side. We watch my wife runs half marathons and 5Ks, and she's done a couple marathons as well. And it's like when I'm watching everyone go by, I'm just like, oh, like everyone, you're just like, damn, but they're fast, it looks painful, but it's like I'm sitting there going, I've had 3 joint replacements. I'm under 40, and I'm looking at this like, you guys are doomed the way you're damaging. So part of our deal with her has been that she needs to run with these good running mechanics. And we won't run further distances until she builds the muscular endurance and the strength to be able to maintain that posture, that good running technique all the way through, which is way harder than just running, right?
Yes, exactly.
So you got to run well, just like you got to lift well. Yep.
100. You got to do everything you do. You should be doing it well. And running
don't
no
just
different.
do.
Do it well. Exactly. Next slide. Okay, so if you look at my client here, this is a different client. You see that internal rotation. You see the popliteal fossa, the backside of her knee, rotating in. And so what happens is the femur, your thigh bone, relatively rotates in, but your tibia, the lower leg, actually rotates out. So if you want to play that video on the right side, you'll see this actually happen. And this is what causes and drives that valgus knee. And ultimately, you see how far that knee rotates? Like her knee is not aligned at all on either side, but it's just worse on her right side. And that's exactly what you're talking about, Robert, that you're going to be walking 10,000 steps if that's your strategy, because you are going to create compensations. You are going to prematurely wear down your joints. So it's really important that we teach our clients an optimal strategy for doing these things. And that's what our sessions do. I should say when I say ours, I mean collectively our sessions as fitness professionals should help our clients develop these strategies to help them better walk, to better run, to better do the things that they ultimately want to do.
So if she's doing this in just like a slow static march like this, she's doing this with probably every stride that she takes. So she's creating like a Vargas bow of her tibia and fibula, right? And you'll start to see that almost like she's been on a horse, right? It's like starting a bow. Now imagine that recoil up the hips and to the back and everything. It's all got to shift, right?
Absolutely. And that's the importance of when somebody says, "Oh, I'm a knee specialist," I'm like, you can't be a knee specialist unless you're looking at what's happening down at the foot. Which you're looking way up above that. You got to be an everything specialist, because everything is exactly as you're saying is being impacted, and your knees probably being driven by one or more of the other areas, as you mentioned earlier.
We're so on the same page with this. We should work together. We should.
we should really create something together.
We should do some webinars together. Yeah, this is great.
Exactly. Our next assessment is a squat. So we go from static posture, standing, and then single leg stance, but then into the squat. And what we're really looking for is, can that person get anterior pelvic rotation? Because when they can't, a couple things are going to happen. Just like you see on the image to the right, let's go to Sarah on the left. She's getting anterior rotation. It's not just of the pelvis. So when I say anterior pelvic rotation, it's really the entire thoracopelvic cylinder, or the entire upper body, or I should say trunk, is leaning forward. That's the pelvic rotation. is happening around the hip joint, but it's a whole entire TPC, that thoracolpelvic cylinder, that's rotating anteriorly, not just the pelvis. What happens to a lot of our clients with hip and knee issues, as well as back issues, and this is why they're all intimately related, is you see the client there on the right image, he's just going directly into posterior pelvic tilt, and that's why your clients will shove their knees forward, because they're not getting anterior pelvic tilt, which will keep the knees back over the foot where it belongs. Even though you see Sarah's knees coming forward, they're not coming forward over her toes. They're coming forward as they should, because she's getting that anterior pelvic rotation, or anterior rotation of her entire upper body. And that's why I said this is such an important assessment, and ultimately it's such an important strategy to teach our clients how to properly anterior pelvic rotate. And we'll get into that as we get a little bit further into the corrective, and you'll take this on a little bit further into the functional progressions.
So if a client is squatting like we're seeing the gentleman on the right here, that's going to tell you right away, as they are so vertical, the only way he can get down is by incorporating more knee flexion. So right away, we're going to see or assume that we're probably dealing with some rather tight hip flexors and some tight hammies that aren't allowing the pelvic girdle to tilt out at all to allow him to hinge properly, right?
Absolutely.
Would you assume there's some stent up to tight pectorals as well, and maybe another sternocleido, all that, the inverted C components all collapsing forward? That's what's stemming all the way up through the chain?
Absolutely. So again, your corrective work is going to involve all those areas. You got to release some areas, and then you're going to need to do some correctives to help them actually utilize the right muscles. So the last assessment, again, this will not be the only assessment, but is forward bend. And this is, again, another huge assessment, because this is everyday life, right? And this is what drives me crazy when surgeons say to clients, oh, you shouldn't do deadlifts because they're bad for your back. I'm like, well, how do people bend forward and pick something off the floor? Please tell me how to do that. Go back and ask your doctor or your surgeon how to do that then. Because you shouldn't do deadlifts if you do a deadlift like my client on the right. But again, if you have proper hip motion like Sarah does, absolutely. And we should be teaching our clients how to bend forward appropriately. So if you look at my client, there's 3 specific things you'll see non-optimal. And this will tell you a couple things about their body. Number 1 is you see the pelvis shifting way far back. And that's a very common thing, because why is it shifting so far back? Because they're not getting anterior pelvic rotation. If you look at Sarah over here, now remember, recognize that Sarah was trained as a professional dancer, so she's a little different in her body mechanics. However, it's more what should happen, where most of us are more like what my client Larry is doing on the right side. But you see that Sarah's keeping her pelvis pretty much right over her ankle, not shifting backwards. That's ultimately what we should be able to do in a body weight forward bend. Number 2, you see the increased thoracic kyphosis. You mentioned that a little bit ago, because that sort of feeds into what happens down below. Yeah. Number 3, you start to see the extension of the head, where you see Sarah's head and chin are tucked. That is usually a neural tension issue. That means the client probably has some kind of spinal stenosis, and most clients over the age of 60 to 70 to 80 to 90 have spinal stenosis. So that's going to be a very common issue with those as well. Spinal stenosis is just a narrowing of the spinal canal. And this is very common that you'll see your clients, and you also see them bend their knees as well. And this is another reason why your client, when they're squatting or trying to learn the hinge, they feel like they're going to fall backwards, because they're shifting their weight so far backwards, they're not able to keep it over their feet where it belongs, and therefore, because they're not creating enough anterior pelvic rotation. So it's just another way to look at what they're going to do in everyday life, and also what we're going to need to help them train is that that anterior pelvic rotation, or that hip hinge pattern.
So it's too much posterior displacement for Larry here. Can you explain a little bit more of the spinal stenosis and just how that, especially up in the neck there, like that's kind of feeding his forward head action is what you're saying, right?
Correct. So spinal stenosis means narrowing. So just imagine your spinal canal. Obviously, this is not how big it is, but just imagine the opening is this big, okay? Now, what happens with spinal stenosis is over time, and this is going to happen to all of us to a certain degree, the spinal canal narrows, and where the nerves are coming out, the neural foramens, where the nerves come out of your spine, the neck, the mid-back, and the low back, those openings will also narrow because of degenerative changes in osteoarthritis and thickening of ligaments and soft tissues and things like that. But so what happens is one of the reasons or one of the strategies that your clients will do, and this is really why your clients, we talk about sitting and how sitting is not great. So it really isn't great. But what really creates that C-curve posture is because the posture that helps create more space in your spinal canal is posterior pelvic tilt and lumbar spine flexion and pretty much spine flexion. And I'll see if I can demonstrate it in my screen here. But that's why your older men and women, they walk around tucked under and they're all flexed forward like this, because that's a very spinal stenotic posture. It helps create more space. However, it creates more space in the spinal canal, but it also inhibits them from properly hip hinging because it's tucking their pelvis under so much, it's flexing their spine so much, so they're not able to keep a more neutral spine or get more of that anterior pelvic rotation. So spinal stenosis really feeds into a lot of the inability to get anterior pelvic rotation.
And is that reversible? I mean, to an extent,
No. Once a client has spinal stenosis, they have it. What we want to do as health and fitness professionals is minimize the progression and then give them a strategy for creating space without having to compensate through that posterior pelvic tilt so much. The best way to do that is through breathing. Like I said, that's a topic for another day, but breathing helps give you space in your rib cage and your spine, and also really doing myofascial release. And now we're going to get into the corrective exercise strategy, and I'll actually briefly talk about breathing here in a moment, because your corrective exercises will help you address the things you found in your assessments. So you'd want to do release on those pecs, the hamstrings, those posterior hip rotators, maybe even the hip flexors, the muscles that are short and tight, pulling people into these postures, because that will help them align so that you can then do your correctives, which I'll show next. So the address phase will help address the issues you found in the discovery phase or the assessment phase. So next slide. And this is just a brief outline of the things that you most want to release. So the glutes, a lot of our clients need glute release because, like I said, of that posterior, I should say the spinal stenosis, and also some of those patterns that we've learned from over gripping the posterior hip complex. The external hip rotators and the hamstrings for sure. And you can throw in there the pecs as well. You can throw in there the some of the hip flexors as well. Then you want to activate the core and hip stabilizers, and I'll show you how we do that. And then education is about the cueing. Cueing your client to be more long from the back of their head, to breathe more into their cylinder, to not drive their pelvis forward or over squeeze their glutes, as you'll demonstrate as we get into the functional patterns. So the first thing we do is do our release, and you can click on that video right there. So this is just one example of the release we would do. We would release the posterior hip complex, and I'm just leaning into the balls because a lot of our clients cannot get on foam rollers. So this is a nice, easy way to release the glutes. You could also do it in the side lying position to get more of the hip flexors and the lateral thighs. I'm just doing a small fall out with the knee just to kind of release and do some contract relax with the hip rotator. So just, you guys know how to do foam roll release, so we don't need to spend a lot of time on that. Next slide. So next is breathing. So if you want to just cue that up, yep, there you go. So I'm aligning my thoracopelvic cylinder to the best of my ability. And this is called the happy baby position, because this position will allow me to put my cylinder in the best position, allow you to put your client's cylinder in the best position, and then do three-dimensional breathing. And you'll see me breathing into my rib cage and also keeping the ribs down towards the floor. For some of your clients, you can bring the legs up as long as they're not distending the abdomen and they're still able to do three-dimensional breathing. So I can still maintain my cylinder, my head and neck, and breathe into the cylinder. Because if you look at the position I'm in right there, if I put myself upright, that's ultimately going to be squat position. It's going to be my squat, my deadlift, my hip hinge type pattern. So I'm helping to set up the posture and the movement that I'll ultimately do as I get into the upright position. But again, you can still keep the legs down. Don't let your clients lift their legs if they're distending their abdomen, which a lot of our older clients will do. They will still get plenty of benefit with the legs down and doing that three-dimensional breathing into the rib cage and into the lower abdomen. Okay, next slide. So that's the first of our 3 corrective exercise patterns. I know you love this pattern. So if you want to cue up the video on the left, this is what a lot of our clients will do. They're driving their pelvis back that direction, back towards their head, because they're basically using their quads to push themselves back that way.
That's my favorite part, man.
Yeah, so I'm like, yeah.
What are you doing?
So I'm like, what are you doing? This is not
I
good.
love it. Look at
So
this
for a lot,
face. That's my favorite. I love it.
you know, I just did that a few times just to be funny, and people are like, oh, I love that
People
face.
dig it.
Wait for that
Yep.
face.
Yep.
So for a lot of your clients, and I think you do this as well, Robert, a lot of your clients, they don't have, their legs are short. And some of your women, their butts may be wide. And not to be disrespectful, there's just not enough space to do a proper hip hinge bridge. So you need to elevate their feet so they have more range to work with.
Absolutely.
As you can see here, I'm maintaining that cylinder alignment of my rib cage, my spine, my pelvis, and I'm really creating that crease, that hip hinge, and that's what the key is to this pattern. Don't do a Pilates roll-up bridge. There's nothing wrong with that, but we're really trying to groove the hip hinge pattern, and that's why we love this pattern, and I think you're a big fan of hip hinge and bridging and things like that as well.
Yeah, I'm going to give you guys a ton of stuff on this in just a minute. That's good stuff.
We're just about done. We just got we got one more exercise. Next slide. The last one is hip hinge. Again, it's aligning that thoracopelvic cylinder, and if you look at the line, you notice how I'm not shoving my hips back that direction. It's really teaching the client to keep their hips more over top their feet, not shift the weight back into their heels. That's why they tend to curve their back, because their weight is going so far back towards their feet, or behind their feet, I should say, that they have to start flexing their spine forward so they don't fall backwards. When you do a proper hip hinge, you want anterior pelvic rotation so the weight stays over the foot, and you're able to load that posterior chain, the glutes, the external hip rotators, and the hamstrings, and you get that nice eccentric lengthening of that posterior chain so that you can load the hips and use them appropriately. And then when you come up, you're coming straight up, not driving that pelvis forward underneath the thorax, or I should say in front of the thorax.
So how far is too far hip displacement? You're saying it's when the thoracic the thoracic spine will start to round over, meaning they're displacing too far? So that kind of gives you your indicator of like, yeah, because we'll teach, especially with like, rack pulls or with a kettlebell swing, we want to be able to put our center of mass over that implement. So we'll teach pretty good hip displacement in the back to get that good hamstring stretch, but not at the expenditure of the thoracic spine round.
Correct. Could you just cue that up and just stop it like when I'm in a down position? So you watch it as I hinge. So stop up, come down just a little bit further. So right there. Because if I had my arms straight down, that weight would be actually hanging straight down between my feet. So it's basically exactly what you're saying is that the weight would still be down between my feet. So if you're going to do a swing or a throw from that position, you'd still have that weight down between your feet. So that way the center of mass is still right over top your feet.
Copy that.
Yep. Next slide.
Got it.
So those are the three correctives: breathing, the hip hinge, as well as the hip hinge bridge. And that really sets your client up for all the functional movement patterns, which you'll go into now. And that will, again, like I said, really set your client up so that they're aligned and then they're using their hips in the right manner.
Yeah, I'm really curious to learn more. I have this slide in mine as well. So when we get done, you guys, you'll all get to see more of Evan's contact info as we switch over. But I'm really curious to see, I'd like to do another talk with you about your breathing mechanics and your setup.
For sure.
I watch you do and go through your steps every time when you do some of these live on Facebook and some of your video clips. I'm really curious about that. So maybe we can roll this back here one of these days and do a second one and chat about that a little bit more.
Love to.
So we're going to get a little bit more practical, and I just want to do like a real brief kind of explanation of where a lot of this comes from with me being in the world of a thrower. This is Ulf Timmerman, and we have something called the Timmerman approach, which, as we talked about earlier, it's basically preventing and reducing degeneration via poor movement or excessive loading through the knee, the hip, and the back. So Ulf Timmerman was a shot putter. He was like a 72-foot, 73-foot shot putter. He was exceptional, one of the world's best, but he blew out both of his knees, as the story goes that I was told from my coach. And for like 18 months to rehabilitate his knees, they just hip hinged and glute bridged him. They did no knee flexion or very limited knee flexion and really limited vertical loading on him. And as he came back 18 months later, his first or second competition, still supporting the knees with some braces, but he ended up coming back being the first man ever to throw over 75 feet. And really this was with, non-explosive movement. It was just more or less evening out a body that had been so overdeveloped and so damaged. They were trying to just hinge him back to where he was more athletic. And, already a big athletic guy, he found basically and filled in his weak spots. So being a thrower myself, I took a lot of that story and that design, that idea, and started to apply it to myself, but also to, my older adult clients. And so here's me throwing the hammer back in the day. If you guys don't know my story, I've told it many times online. You can check it out on YouTube. But I just threw it all on here, from my hip replacements to my carcinoid tumor in my lung to wrist surgeries. And these are the hips that I connect and I work with now. And my doctors and all of my clients and such have all kind of heard that story. And a lot of my individuals are referred to me via that experience personally. So that personal experience plus my Timmerman story and all the research and all of the my excessive mindset has all kind of come into the idea of developing this philosophy and how we work. And really it comes down to just this basic idea. When working, like if someone came to me and said, you have to build like the best program you can for a client, it would basically be 3 posterior chain activated exercises to every one that I do on the front side or that I do to the rest. And really that is like our pure emphasis when we bring our clients in here. Teach them how to hinge properly, teach them how to train the backside of their body because it's so neglected. So we teach a proper hinge, good mechanics there. We like to complex or build a lot of our movements together. So we'll do like proper pickups, a hinge pickup into a loaded carry, a proper pickup to an overhead placement, just kind of emulating some of the movements for life. And we work on a lot of our retraction strength, working on, I call it the Superman position, where we open the chest and the shoulders and we build that strength to help kind of feed into our daily life postures that we need to stand in. And so we'll learn how to row, how to retract, and then add movement to that and complex those together. Really, it's like, it's ways to train our people to move more efficiently through their daily life mechanics, but from the backside forward, where the majority of us go and exercise, and it's from the front side down, more or less, everything that we can see. So we're training all the non-C muscles, the ones that are on the backside. So we have that focus, rows and hinges, really 1 and 2. And then we do splits, overhead carry actions, anything that's going to be pulling or pressing or raising from overhead, and then all of our loaded carry actions. You'll notice that we don't really have a whole lot of horizontal pushing or pressing actions. I just don't see a huge value in, if I only get to see people twice a week for an hour, in implementing those or practicing those, when there's so much more that I could do and to benefit them. So we really like to complex a lot of these together. A lot of our area as well will start from teaching our clients how to hinge and be able to move a pretty good and pretty heavy amount of weight from above their knee. So we're benefiting so much of the bone density and the ligament and joint tensions and strength development, but we're reducing their risk of injury by increasing any excessive ranges of motion, what I call the exposed positions. I want to keep them away from that. So we work on our really good hinging patterns. We're going to start horizontally, work to a vertical, and then a vertical bent knee, which all of us as pros, we call squatting or deadlifting. But it's a way that I like to teach it to my clients so they understand the hips have to move first, the hips have to be incorporated. All of our split stance work, we'll start with deloaded. Again, there's more information about this on some of my YouTube channels, and it's all free info. You can check it out on there. How we deload, then we'll work to body weight, progressive resistance, and then consistent loads like you see Linda doing here, just a regular weight that doesn't change. And then drags. I see such a huge benefit in dragging and pulling weight, especially for the hip and the knee. This is a great way to get that pressure placed through without a ton of vertical loading. You're learning how to displace your body weight to use your inertia to help the creation of movement. You're learning what it's like to displace your body outside its normal balance and its normal center of mass. So you're working on some fall prevention components. There's a lot of good stuff that comes from dragging and working on. We'll do like short progressive resistance inside the gym where we simulate drags, but also taking them outside, letting them pull sleds for 100 meters, 300 meters, depending on the distance we can work with. Okay. So for the discussion and the time we have today, what I really wanted to address was like the base component of how we will teach somebody to hinge, in the hopes that you can all apply this right away, as you kind of come into your next couple of days of training. we have something that we call the movement observation form. I'm not big on assessments. I'm not a huge fan of using that word with our clients. I basically want to observe them as they do things, and then I will fill out this form without them really knowing it. That's kind of giving me my assessment information, right? So the first one that we do is just a basic sit to stand. And I will have a client do that to a chair. We can adjust the heights based on, their comfort. Are they able, capable? It's kind of a mix of FMS inspired movements where I have a scoring component to it. So if they are uncomfortable or they don't even want to attempt to do the movement, it's a 0. If they try it, but they're not successful, meaning they go down into the sit to stand, but they can't get out of the chair, or they have to hold on to me to help them do it, then that's a 1. If they can do it, but it's ugly, that's a 2. And then if they can do it and it looks great, then it's a 3. And then I'll kind of write in there, oh, they did, to parallel, just below parallel, etc. So we build that into the workout where it just says on the board, we're doing 10 sit to stands. But as they're doing that sit to stand, I'm observing and seeing and kind of making my notes of what they can do. Did we eventually get up to the point where they could hold weight? And this is even on day 1. We're not trying to do any kind of max by any means, but were they comfortable trying it with 10 pounds in their hand or 5 pounds in their hand? And so just a real basic piece that we put together, there's just a real basic assessment that Christian teaches as well, where you do a sit to stand and then you walk, I believe it's 8 feet, around a cone, and you come back and they time that. So we kind of took that to a next level. We'll do 5 sit to stands. And then we extended, just because of the length of the gym that we had, we'll extend that out 25 feet, have them walk around a cone or hit that end contact point, and then come back. And so I can work on the mechanics of my sit to stand. I can add additional load to this. I'm getting a carry component, which is basically a goblet carry. And then I'm getting the ideas of transitioning with weight, changing direction, learning to decelerate, to descend it, to unload, to re-engage it, to come up. So we're getting a lot of different practices, and the idea of starting and stopping with load as if they were carrying groceries, having to move in transition. So the complexing components of building a couple different pieces together, but it gives me so many good pieces. I can observe their posture while they do this. I can observe their balance as well. I can see Jerry's left knee. This is pre-knee replacement, how much it vargously collapses out and how his right hip counters that with every step that he takes. So I don't need to have the person go, you're being assessed right now and I need to measure you. And I can do this as a observation component and just collect some pretty good data from them right from the get-go, okay? So that sit to stand is a piece that I encourage you all to use. Again, I don't have a name for it. It's just a little carry test that we do. We do 5 sit to stands, 25 feet down and back, 5 sit to stands, 25 feet, 5 sit to stands, 25 feet, and sit down. And we will time that. And I'm not timing it for a max effort. I'm timing it for a consistency. So if it takes them a minute 2, a minute 3, and then 59 seconds, then I can see that we're pretty good. But if they do a minute 2, a minute 3, and then 49 seconds, I can see that they were kind of sandbagging in the beginning, or they're getting more comfortable as we go along, okay? So that's something to focus on. You'll see with the sit to stand, we need them to stay fairly heel dominant, to be able to unload onto the box softly so they're not just dropping onto it. That means the height of the chair is too low. Some of the common mistakes, you'll see them rocking to get up and down. That means they haven't built the hip strength or the core strength to be able to transition yet. So adjusting the load or the height will help. Letting the weight drift, meaning that their weight drifts out in front of them. They're using the weight to create momentum to help them come up, or their back, like Evan was talking about, just rounding over heavy because they don't have the proper posture and the mechanics set in to be able to hold that position while they come. So a lot of times it's just the depth of the sit, or it's the amount of weight that they're holding to work on that. Something that we have is the triangle. We talk about working our triangle. If you're seated in a chair, you have one end of the triangle goes from your heels straight up to your chest. The other one goes down your lower back, and the other one goes across your thighs. So it's basically like a pyramid tilted on its side. And we want to encourage pushing down, driving your head up, and pushing your butt back all at the same time to keep that triangle really tight. And if any of those edges of the triangle give, the knees are going to drift, the head's going to tilt, the back's going to round, something in there is going to give out. And that's going to give you, via your observation, it's going to give you your sign of where are they weakest at, right? So you want to watch for that knee drift, the head tilt, the round of the back. That's showing you that one of those 3 components is fairly weak. Okay, on the carry itself, you'll see, ideally, we want to see small, quick steps even though we're working on larger gait components with our clients to keep them more mobile, when transitioning with heavy loads, we want to shorten the gait just a little bit, but speed up the tempo. So it's almost like the Flintstones when their feet are running under their right. So we want to kind of get that momentum going. I always tell them, like, whatever you're carrying, it's filled to the brim. You don't want to spill it, but it's also on fire, right? So like you got to go quickly, but I don't want to spill it as I'm going. And then the turnarounds with our clients in the beginning, turning around with weight can be a little tricky, can be a little dangerous. So a lot of times we'll have them walk up, properly put it down, turn around, properly pick it back up, and then transfer. And our clients that are a little bit more advanced, we'll let them turn, because twisting or turning with weight or multiple weights can be a little tricky on the joints until they're trained how, okay? Common mistakes there, lumbering side to side as they walk, bouncing up and down, or technically walking. That's why I call it a carry. It's not a walk. They're basically doing their regular walking stride. We want to work that tempo a little faster. And then our cues as we do this, you have somewhere to be. Like, get there quickly, work your tempo, and we'll go step, 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 and I'll clap with them, right? You set the pace as you want them to go through that, so they know exactly what you're expecting, okay? So that's a great observation point. It's a good drill to do, but it gives you a lot of information. So that's kind of our way we assess or we observe our client to see what we're working with in the beginning. And then we kind of dive right into our blueprint. This is our blueprint. I have a great deal of information of this on my YouTube channel as well. I keep referring you to that because it's free and it's all on there, and I elaborate on all of it. So I don't want to do that now. But the hinge mechanics, component number one, is from the most simplistic. This is step number one, the very first glute bridge I would do with them, all the way down to the point where now I'm ready to get vertical, all the way down to where I'm ready to get vertical with a bent knee. So I tried to make that as progressive as I could, step one, step two, step three. And it's really, in my opinion, it's the only movement pattern that I can coach, or that majority of people can coach, where you can have that 1, 2, 3 step. With the shoulders, with rows, with hinges, it depends on so many of the physical limitations. If I should jump ahead or where I could start with. With the hinge, you can basically start everybody here and then work them up. Even if they do this and they're like, this is so simple, at least you did step one. Because the last thing you want to do is assume, based on looking at someone, is that you should be able to do blank. And then when you try to have them do that, they fail. So now the expectation is, you thought I could do this and I proved you wrong, I can't. And you feel a little bit bummed out because you thought I could, but also I'm embarrassed because I tried to do something that was just fairly simple and I'm not ready for that yet. So I'd rather always start with the most simplistic movement. And if we're like, did 2 of them, easy, we're on to the next one, let's keep moving, okay? So these are called chevrons. That my wife made these. I love these. And because it's resistance training, our nickname for these are resistrons, which I feel like could be like a new like transformer, the resistron.
That's right.
Yeah. So basically, it's a little progressive arrow for you. This is a high floor box bridge. So Betty 92 here is doing this bridge for us. If you can't get a client to the ground, we will have these boxes placed here for them, 18 inches, 12 inches, 6 inches. Really at 6 inches, they're ready to go to the ground. So this gives you a good opportunity to practice these hinging movements, maybe with individuals that can't get to the floor yet. And then you'll also notice that we can start with like body weight to start off, then add progressive resistance. That's our next step here. So we started body weight, then we can go to progressive. This is what I call a self-anchored bridge. I don't know if other people have done this. Maybe this is something that I invented, but using just 3 mini bands, we loop them together and you can basically create a belt of the band over. And as the individual bridges, which most bridging actions, the upper body is fairly passive unless it has something to push on. So what we're doing here is opening the palms supinated and then retracting the shoulders down, which creates that scapular retraction and creates the platform that you want to bridge on. And we call it the wheelbarrow effect, where everything tilts up and everything comes back. Like Evan was saying, we don't do the Pilates abdominal roll or the spine roll. Everything lifts as one, okay? So we're locking that in on the scapula. That's your platform. And then the self-anchor, the band pulling down, the arms are actively pulling down. So the whole posterior chain is on from the erectors into the neck all the way down to the calves, right? We can actually create this and make like a full body glute bridge with posterior chain being the dominant primary movers all the way through it. So start with body weight, add the progressive resistance. Eventually we would add consistent load to that as we go through, or you could add continuous loads as you go on, meaning that you'll have a bag and a band strapped over as we go through that. So that's kind of the step one piece that we go to. Then we're going to go to floor bridges. So I have one with consistent load here. Susan's doing just a regular a barbell glute bridge. Like Evan was talking about, the range of motion for the untrained individual, starting them with their feet elevated teaches them a greater range of motion and how to activate that wheelbarrow action. With our clients that have a pretty good understanding of how to do this, we can work back to these basic components here and load them up. I love the basics. I love mastering the basics and excelling them, not to make them more technical, but to make them more difficult in terms of the load that you're adding. So we'll add an abduction band plus a self-anchor band like you see Steve doing at the top here, or just additional load like you see with Susan. Okay, and then our next bit, now we're elevating the feet. So we're ready to increase that range of motion, get them stronger. You'll notice Jerry and Susan, this is an older video. We used to teach palms down on that self-anchor, but that internally rotates the shoulder a bit, and it's kind of encouraging that like forward crunch pull down, where I really like the palms open now. So really, I shouldn't even show this video anymore, but they're bridging so well and holding themselves in such a good position. We watch the chest and we make sure the chest is moving with that wheelbarrow action, right? Or else you're just floor humping, like you're just pelvic tilting the butt, your butt winking, your butt tucking,
Correct.
your butt gripping. Yeah, you've
Right.
got to get that leverage action in there. And I love it that was like one of the first things. When I brought this to Evan, I said, I want to talk about this in our webinar. He goes, how do you coach? Do you butt wink? And I said, no, we don't. And he goes, okay, good. We can talk about this then. Because it's really getting that idea of like, how do you activate the glutes without teaching that excessive pelvic tuck under? And we just see it so much with everything today. It's really a challenging bit to go through. And then we're ready to elevate their shoulders. So Jerry here, this is a hip thrust. Typically thrust, in my opinion, means that you're going for a faster tempo. With a lot of our clients in the beginning, we're just doing a shoulder elevated bridge, meaning we're not working on these fast tempos where we're thrusting the weight at a higher speed. So we'll hook the band on, and then with Gary, we're still elevated. Okay, we have him up on a hip thrust bench on the back here, and then he's able to notice his tempo. He is doing a consistent thrust here where he is coming up pretty quickly, right? He's driving up fast, working that slow tempo down, getting that eccentric, but the whole chest is moving, his head's locked in, like everything is one solid action as we come through that. And these are difficult teaching mechanics to work with your clients, okay? But once you teach those movements well, and they know how to break at the hip, and we reduced how much vertical load we placed on them by putting them horizontal, right? We can teach a pretty safe mechanic of the hinge and load it pretty well and make sure they're ready to go to something vertical. So Erna, as she goes here, we're now in a vertical hinging piece. I know we're running a little late. Everybody give me like 5 or 6 minutes. I'll get through these here real quick. We're going to deload by just placing a band overhead. And as she braces and displaces her hips and pushes back, she's actually creating a little bit of a traction for the spine by engaging down on that band, but she's reducing her spinal load and her pressure placed through her hips by the band taking up that slack. So let's say she's 150, she's not, but let's say she's 150 here. That's a 50-pound band. And at the bottom, as it gets doubled, it's going to hit that 50 pounds. So she's about 100 pounds of pressure through her hips and her spine there at that position at the bottom. And so she's able to train the range of motion, maybe even a little bit further than she is comfortably able to do so, while deloading her body and practicing a movement that maybe would hurt her in the past. We've now practiced it on the ground. We've increased range of motion. We've built strength there. And now we're exceeding range of motion in the vertical position. So it's a pretty safe way for us to teach this standing hinge mechanic before we're ready to start adding any kind of load. We'll take that support away and have them do just a traditional hinge component now, but also with the band pulling them back into position, right? So we're teaching like a standing glute bridge now. As Cassie stands up, she has to be able to activate her glutes and stand tall into it, but notice that we call it the ski jump. Off her butt at the back, she's not fully tucking underneath and butt winking. She's just standing up straight and allowing the band to support through her hip. To add a little bit more posterior chain, we're adding the band around her arms with the retraction, the abduction around the arms, just to get that backside of the upper half active too. So now, like if she were holding a barbell doing an RDL or a rack pull, we're kind of simulating that muscle action without that weight, right? I want to take everything back to like, if I'm ultimately going to have you do a deadlift, how can I train all the pieces of it, but make it as close to a deadlift as possible? Everything on the backside of the body is going to be on deadlifting. But if I take that band off of her and just have her hinge, her upper body's not doing anything. So now we're not actually training like we would deadlift, okay? So it's as close as I can get to that as possible, right? So I'm a big fan of that piece there. Then the self-anchor, this is Jerry post hip replacement. So we're still working some range of motion with him here. It's not perfect, but we're getting there, okay? Self-anchor to the floor. As he hinges, he's getting a little more exposed, but the band gets lighter. And as he comes up, he can take more of that pressure as he's in a bit of a stronger position. So I really like that piece before we're ready to vertically load. And then when we get to that position, it could be however we want. I love these angle 90 grips because I can rotate the handles, and they're so comfortable for clients with arthritic issues or elbow, shoulder issues. It allows that rotation and the retraction, where with the bar and a pronated grip, we are encouraging that forward internal rotation at the shoulder. So either a hex bar or some type of handle like this, I think is a great piece to go to, okay? I know I'm turning and burning here, gang, but I want to give you guys all this stuff so you can try to implement it a bit with your clients. All the info Evan was talking about and this, hopefully you leave here having some pretty good stuff you can plug in with people. All right, here is our deloaded squat. And so here's my missus, my wife, Keegan, demonstrating this for us. Hinge of the hip and then displace back just like a traditional squat or a deadlift if her hands were down. But we're getting her to deload a little bit, take the pressure off of her by holding onto that band, and she can make a little less pressure in the back and the hip and the knee, but allow maybe a little bit deeper range of motion for her to train because she's a little bit lighter, right? So it's kind of that in-between piece for us. We're almost to the point we're ready to do this. Let's find an in-betweener, like a 0.5 version of this, and then we're ready to move to the next piece. I love practicing these hip hinges. I call these skier squats, okay? Where Jerry was ostracized. He got kicked out of the group. He had to go out there and do it. He needed a higher box. That's why I had him out there. But, I call it the thinking position. Elbows on the thighs, hands under the chin. And then we're working on that tilt, okay? As Evan was talking about, it's not a huge displacement. It's up, right? I want to work on that pelvic tilt up. And then I want them to pull their shoulder blades back. So when they get up into that high bridge, they have that huge eccentric stretch in the hammies. Their glutes are eccentrically stretched, their rhomboids, lats, posterior delt, all that's firing to keep them upright. If I just told you all of that and said, what am I describing? You would say that's a deadlift or that's a hinge or that's a swing. So we're training those pieces while working a lot of mobility in here, okay? Plus we're still deloaded. We haven't put any vertical pressure on the spine yet. So we're able to work these mechanics, practice these mechanics. And as we get a little bit better, now we can start to progressively load. I'm a big fan of this one. I love doing stuff without the hands, because people have to learn how to embrace it into their body, right? And they can breathe into that. They can retract into that. So here's a self-anchor version that Steve's doing where he's a handless. He's just holding the sandball. And then here's another version, Linda, and she's holding kind of in like a front squat or in a racked position. She's able to work that progressive load. She has a tendency to push her knees out too far. So I'll put her into this band triangular position where the band kind of touches the aspect of her knees. And that way it keeps her within the frame, right? Most people valgously collapse. She likes to get a little external rotation and a little extensive range on the knee there out to the side. So we'll kind of guide her by putting some bumpers up, if you will, to let her know where she needs to stay at. But think of that increase in core tension and pressure as she comes up. And then as she comes down to deload, it's fairly neutral or almost nothing there at the bottom. So they're learning that what I call bite, the engagement of the muscle to get out of the bucket, to get up into that strong position. And then two of our additional pieces here, just our traditional, consistent hex bar here off the floor, one same weight, working good posture. I started this with Ruth from the floor up, all 12 of these steps to build her up to the point where she could do this. And a couple of our clients still were not quite ready for the hex bar, but we'll be able to work some of these, triple or quadruple pulse deadlifts where they're elevated, and we're working on keeping the proper posture, work into that 1, 2, 3, 4, 5, 6, 7 pulses, 8 pulses, and come back up. And they're working down into that range of motion, okay? I think these are all really great pieces that can kind of lead into some really proper hinging mechanics. The more appropriate we hinge, the better the back, the better the knee. So that's where I think like all these fit together, rather than saying, like Evan, like you were talking about, you're not a knee specialist, you're not a back specialist. Like all of this, it's all a chain. They call it the posterior chain for a reason. It's because all of that has to work well together, right? And I describe it a little bit more and kind of go into further detail in PFP Magazine. If you don't have a subscription to this, I'm happy to send it to you. You can email me and I'll send this over. I'll put it in the PDF as well. And it's just a little more description of how we start bilaterally with all of our hinges, and then we work our clients to unilateral components to help develop and seek that muscular equality. I have a little promo code here. We're coming up to our last 3 webinars of the year. So if anybody's interested in joining that, please check that out. You get all of them all the way back. So if you missed anything, you'll receive all of the PDFs. Here is all of Evan's information. If he has any further info or anything else, he already gave me a PDF to give out to everybody. That'll be in the folder. Evan, I'll let you talk a little bit more about that in a second. But you're going to get the PDF of both of our presentations, the video of today, plus the additional little grids, the templates, all that stuff. Everything you've seen of mine will be in there, so you'll have access to all that. You'll get my YouTube link. I'll put Evan's YouTube link in there too. So if you have any further questions or information, anything you want to seek, you know how to get a hold of us, and you know where all of our content is, where you can take a look in there. Evan, do you have anything else you wanted to share with them real quick?
No, it's great. No, it's really great information. And I look forward to doing more with you. And I want to say thank you to everybody for being on and staying a few minutes late. I know I talked a little bit longer than I should have. And
that's all good.
Thank you for having me on. You can find us at IIHFB. That's our Instagram page. We're at Fitness Education Seminars on Facebook or YouTube. And we have a free newsletter we send out, free videos, content almost every single week. We're sending out free information on Facebook. And we also have regular posts where you see a lot of our videos and where Robert likes when I make funny faces on Instagram. So
your Instagram's great, man. You give out some really, really good content. If you guys haven't seen that, check it out. He'll show a video of basically here's what we commonly see, and then he does the face. And then he kind of shows, what the next bit is, how to correct it, and the steps he goes through. And then he'll give some really good detail and some explanation. And I'm a big fan of if you're going to tell me why to do or how to do something, I want to know the why that goes with it. Yeah. And that's a big piece, because it's not just, because Evan told me this is the way to do it. Right. I need to know that process, right? And as trainers, there's too many of us are well, that's how Boyle does it, and that's how Durkin does it.
Yes, correct.
Yeah, that's great that they do it that way, but why did you pick that? Why don't you have pieces of everybody, of pieces that you like? So I love the why, and your Instagram is full of it. You give out great content, and I always try to deliver that too with my content.
Absolutely.
I want everybody to understand why. Yeah.
Yep. Exactly.
Here's my info. Go ahead, Evan.
No, I was just going to say, Jackie introduced me to you a while ago, and she's like, you got to meet this guy. You guys, you may not agree on everything, but you really think alike. And I like people who think and have a reason for why you do what you do. And that's what I truly, truly appreciate about you. And thank you so much for having me on. And I look forward to being on again and sharing a lot more. We got a lot of good things we can do together.
Yes, sir. We sure do. And he's going to be here in a couple of weeks. We're working on a secret project that's not so secret anymore, but we're going to be working on stuff. We'll probably do a couple of Facebook Lives here with Evan and I and the rest of the crew that's coming. So stay tuned for that. Thank you, everybody, very, very much. We are going to sign off now, but I saw a couple of comments that came up for Q&As. But if you're going to head out, thank you. We appreciate you. And stay tuned for other solution sessions coming up here in the future. Thank you, everybody. Thank you, Evan. Really appreciate your time, my man. And we'll talk to you all later.
Appreciate it.
Take care, everybody. All right. We have a couple. I saw 1 or 2 comments pop up. If anybody has questions, fire away now. We got a couple of minutes. And actually, these are just comments of how great we did. Oh, that's very nice. Thank you all. That was amazing. Very, very good. I also got 2 text messages from Jackie. Oh, she texted both of us. She's very proud of us and sees unlimited potential for all of us in our experience in this industry. So that is fantastic. I agree with her. Jackie's the reason that we got connected.
Exactly. Thank you, Jackie. Love you.
Thank you, Jackie. Thank you, everybody. I didn't see any other questions on there. Oh, here's one more shooting in right now. Where will the folders be to access? Okay, so we're going to send out a Dropbox, and it'll my wife sends these out in a really nice email. It's going to have the video link in there of the recording, plus all of the downloads. Everything will be a PDF. The only thing you guys don't get are the videos. We do not have permission, or at least I don't have permission. I don't feel comfortable sharing videos of my clients doing the movements, but all the still screens we set up so it is a picture of them doing the action. You just won't be able to see the video, obviously, of them doing that. So you'll still be able to figure out what's going on there. So you'll get to see that. Evan said he was going to go over the squat position. What is the best type of squat position per person? So Evan, it's a really good question. Shelly just asked that. When I was with John Russin, he did the same thing you were doing, where you were laying on the back and it was basically like a happy baby squat, right?
Sure. Yep.
And then we measured from the ankle to the ischial tuberosity. You know, we measured from the knee to the toe, and then we kind of guesstimated where, you know, the butt would be in relation to the floor. And then we took those measurements and tipped people upright and then traced out those measurements. And we found that people aren't always, you know, square at 0 degrees and 15 degrees on each foot.
Correct.
That's perfect. Sometimes they were 2 inches out and 45 degrees, and this one was at 18 degrees, right?
Yeah, correct.
And so you want to dive into that real quick, just a little bit on your suggestions for squatting mechanics and what is kind of ideal, I guess?
Yeah, we just talked about this last week in our certification course, and there's a lot, obviously, like a lot of things, there's a lot of different opinions about it. What we're really looking for is, the first component is head and neck stay stacked on the thoracopelvic cylinder, so rib cage over top pelvis, to the best of your client's ability. That's the, excuse me, I'm just getting over a little cold here. That's the biggest component we're looking for, is to maintain that thoracopelvic cylinder through the squat progression. So that way, I'm not concerned about so much the angle of the feet. I have the client just march a couple times in place and put their feet down for right then and there. That's going to be the best position for them without modifying their feet in or out, because there's a lot of things to take into consideration, like their hip joint alignment, their knee alignment. Do they have degenerative changes or things like that? But march in place, put their feet in relatively the position they march in. Make sure they align the hip, knee, ankle, and foot. Keep their thoracopelvic cylinder or that torso aligned, the trunk aligned over top of their pelvis. Squat as deep as they can while maintaining that alignment, which is basically what you demonstrated in all your progressions, which is really cool. And like I said, that's why I believe, like, even though we may have some different philosophies, so to speak, we're still looking at basically the exact same components.
Absolutely.
So you squat as deep as you can while you're maintaining that rotation of the pelvis, keeping that alignment of the rib cage to the pelvis. And that's a really good safe squat for pretty much 95% of your people. Obviously, if you're training people for powerlifting, or I should say Olympic lifting, they're going way deeper, but that's generally not when you're training your older clients. You're not doing those types of lifts. So that's really what we're looking for.
Or they're going way wider in like a sumo for powerlifting
and
such, right?
Correct, correct.
So that's sport specific when we're talking about general pop. So do you think people kind of naturally kind of pick the squat position that's most comfortable for them? You're saying through that march, like they'll just kind of place their feet where they think is best?
I do. And again, maybe if one leg's like way out like this,
you critique it a little bit.
Yeah, I'll critique it a little bit, as long as they can get the foot around closer to their other side. It's not causing any hip pinching or any compensations through their back. Then I'm pretty okay with adjusting the position. I don't want the feet completely straight, and I don't want to necessarily want the feet way out like that either. It's just kind of their natural, because all of us are born with slightly different angles to our hips and our pelvis and our hip sockets. So we don't want to force people into unnatural positions because somebody told us, like, everybody should squat with their feet 18 degrees out. It's really individualized that way. It's more that wherever your foot is pointed. So even if your client's foot, maybe one foot's maybe 18 degrees and the other one's like maybe 45 because of a hip problem. Even if their foot goes out that direction, as long as their hip, knee, ankle, and foot go the same direction, that's what's the biggest issue, or biggest concern, I should say, is just keep that alignment. And whether the feet are out or in, or just make sure everything lines up that way, and your client will do the safest squat that they can do.
I train a lot of doctors, and one of them does hip replacements as his area of expertise.
Okay, cool.
And he was talking about the parts that they have. They are trying to create a hip replacement that closely emulates what you currently have. And there's like 18 different ball options, 18 different head stem, 18 different insertions. So he was like, there's 200 and something different mixes of pieces that we can get. That's how different people are, between the cup of the acetabulum, the opening of the acetabular, all of that. Those are all pieces. And so he's like taking piece by piece, trying to match it up, as you're open right there. And it's like, if we look at it that way, if there's that many pieces on trying to create a fake hip, and he goes, that doesn't hit everything perfectly.
Oh, right.
Think of all the different pieces we're dealing with people here, but shouldn't it all be one exact 15 degrees on each? Maybe there's a good starting point there, but there's going to be great variables in there. Yeah. So I dig that. I love it that you have a good emphasis on that, and you kind of let what naturally occurs happen.
Yeah, correct. Correct. Do we have time to talk about the knees over the toes? Because I think that'd be a cool thing to talk about.
Yeah, I got let's do another 5 minutes and we'll sign off.
All right, cool. So people in the industry, we've all learned like, oh, we got to keep the knees behind the toes. And there is some good research around, I shouldn't say good research, there's research around that shows that keeping the knees behind the toes will decrease stress upon the knees. So if your client does currently have knee problems, it may be beneficial to keep the knees behind the toes during squat positions. But I lean more towards you. I would rather just have them do hinge type patterns, keep the pressure off the knees regardless that way, teach them how to anterior pelvic rotate. Because if you look at the studies that say keep the knees behind the toes, if you keep reading the study, it says, but then it puts the pressure on the low back. And exactly what you said earlier in the webinar, do people that have knee problems probably also have low back problems? Absolutely. And that's usually why. They're trying to get the pain away from the knees. So they put the knees back, but then it transfers it up to the low back. And a lot of the low back issues is what is
got to go somewhere, right?
Yeah, it's got to go somewhere. So I'm with you. I'd rather do hinge patterns. I'd rather do more horizontal loading, so to speak. Get people learning how to hip hinge first before we ever get them to doing squatting, if that's something that bothers their knees.
Gotcha. Yeah, I totally agree. I love it, my man. Well, thank you again.
So
thank you, everybody that stayed on with us. This was great. And we're definitely going to do a Evan and Rob part 2 coming up here in the future. So, all right, everybody. Thanks, you. Have a great day.